Hi there, greetings and welcome to another video on surgical discussion. In this slide you can see four different colors. I'm starting from the top left side. This is a black color which represents a dark, hard eschar. If you encounter something which is hard and black and if you percuss it, it sounds hollow, it's good news. Nothing needs to be done here, and the only thing that needs to be applied is probably Tegaderm film, or you can use Cavilon spray or Opside spray. Now to the top right is yellow, meaning that the wound is having infection or having slough and there is an exudate there which is infective. This kind of a wound needs a wound bed preparation, which is the combination of debridement, infection control, moisture balance, edge control and epithelialization. At times you could have a combination of black and yellow, meaning that if there was a black eschar and some people would have wrongly decided to use wet dressings on that, the wound would have become from dry to wet. Now this is a wound which needs urgent debridement, or else below the surface of the dark eschar you will be having infected tissue which will actually cause sepsis. One should know how to differentiate between a black eschar and infective tissue. When it's uninfected, it's hard, and when you percuss it, it is resonant. Whereas when it's infected, it feels mushy, there is loss of consistency, and it smells bad. Now the color which is to the bottom right is a bright red, and this means to say there is granulation tissue with infection. There is something which causes redness there. It could even be a very high protease level. And one to the bottom left is what we are targeting at, and that is granulation tissue. Once it is granulated, it is time for our friends in plastic to take over and do something. Sniff, sniff. Remember that some patients and doctors have very sensitive noses. Don't forget that some patient relatives and the bystanders have even more sensitive noses. So the great smells that we get from food is mainly due to the fats and the proteins. They have a natural smell which is very pleasing. Malodor in the wounds can be very embarrassing to the patient, and it's mainly caused because of amines and fats. We'll get to that in just a moment. As mentioned before, malodor in the wound is caused when the short-chain fatty acids and amines are acted upon by the anaerobic bacteria, or even when the normal tissues have been acted upon by bacteria and there is a breakdown, and this releases short-chain fatty acids and amines. It causes embarrassment, and even the patient feels like withdrawing from society. The organisms that are involved are bacteroids and Clostridium species, which are gram-negative, and the positive organisms are Klebsiella, Proteus, Pseudomonas, and the Streptococci. To eradicate the malodor in the wounds, one needs to eradicate the infection. Therefore, an excellent debridement would help. Also, antiseptics would help to take off the bacteria, and you can use systemic antibiotics in case there is a very severe infection. Remember that as the infection increases, so does the exudates. So wet exudating wounds are usually considered to be infected, unless of course there is a fistula. The different dressing materials that can be used in case of malodor are honey, which is can be used as the tube form, or you can use even the medihoney in the form of alginate. You can use sugar. Yes, crystalline sugar has been used, but yes, people would really wonder why you're using sugar in the wounds. Sugar is even used as a hemostatic agent. You can use yogurt, and yeah, again people would question you in the hospital as to, what, you're going to put yogurt in my wound? Wow, are you a chef or a doctor? Maggots, because they cause debridement, and you know that maggots, especially the medical maggots which are used on human tissues, are non-penetrating, so they don't go beyond the wound bed and they do not penetrate into the intermuscular spaces. They mainly act on upon the dead tissues, and they don't eat into the normal healthy tissues. Another super product used for malodor in the wound is Actisorb. Actisorb, as you know, it can act on it's the same as silver cell, only the advantage is that you have activated charcoal. So it absorbs all the odor causing chemicals and thereby prevents the smell from the wound. When one thinks of wound healing, this is what they imagine in their mind, that there is some kind of a construction work taking place and everything is progressing positively. Greg Schultz, in his paper called Dynamic Reciprocity, is one of the pioneers of wound care, had shown that there are two things that take place. First of all, there is a breakdown of all the unhealthy tissues, and this creates a space for all the healthy tissues to start migrating and then start replicating. When they replicate, they also now attract the extracellular matrix, which first starts progressing and only then the inherent cells will move. It's a very nice paper to read, and I have a separate presentation on dynamic reciprocity. Now, therefore, you need to realize that there is a breakdown and there is a buildup of tissues, and these two things are taking place because of the presence of certain enzymes. There is a matrix metalloprotease, as the name suggests. It breaks down the matrix and it's the protease. There is another enzyme called the tissue inhibitor of matrix metalloprotease, or else called as TIMP. In brief, there is a TIMP and an MMP ratio. If there is more of MMP, which means to say the wound will get broken down severely. If there is more of TIMP, this means that it will inhibit the MMP, and therefore you can imagine there is more of buildup. What usually happens now is that MMP is an enzyme which doesn't know the difference between the good, the bad, and the ugly. Yes, it can destroy the necrotic material, which is ugly. It can destroy the bacteria, that is bad. It can also destroy the healthy tissues, which are good. Therefore, a wound which has a very, very high MMP is to TIMP ratio will become a chronic wound, because wounds don't heal and even the normal granulation tissue is now retarded from growing. Promogran, as the name suggests, is to promote granulation tissue. What exactly is it? It is an ORC, an oxidized reconstituted cellulose. Cellulose is nothing but wood. Okay. Now, promogran, it is a protease inhibitor. So when there is too much of matrix metalloprotease, the MMP will start acting on the promogran. So it is like using a bulletproof vest and getting shot by a bullet. All the enzymes will go on to the bulletproof vest, which is nothing but promogran, and now there is a nice matrix for the enzymes to act. When this happens, the wound starts healing well because all the MMPs are busy going and attacking the promogran material. It contains cellulose, so it maintains some degree of hydration in the wound, and therefore it also promotes the migration of granulation tissue. So use promogran in a chronic wound, and when you suspect high MMP to TIMP ratio. So when you use promogran and you see your wounds healing, now you know that there is biochemical evidence of very high MMP. Remember, promogran needs to be hydrated, and you can't use it in a dry wound, because if it's not charged with water, it wouldn't start working. A wound contact layer is to be used when there are very delicate tissues that you're dealing with. For example, blood vessels, intestines, periosteum, bone, paratendon, tendons, muscles, etc. You don't want the dressing material sticking onto these delicate tissues, and when you pull off the dressing material, you will pull off some tissue also. Therefore, it renders more complications. Wound dressing materials are painless to put on and painless to take off. They are sometimes impregnated with either silver or iodine. It allows a free passage of exudates. It is inert and non-reactive. So these are some of the properties of a wound care contact material. There are different wound contact layers available. It's made up of either nylon or silicone. Some materials, for example silver cell, its outer jacket is made of nylon, so it has a wound contact layer which is impregnated. Same with Actisorb, it is nylon. As far as Mepilex AG, Aquacell are concerned, they have a silicone wound contact layer. So certain layers are present inside a sandwich dressing which has a wound contact layer as the outermost jacket. So one needs to be aware of that, so that you don't simply use another wound contact layer along with the dressing which is already containing one. Therefore it's a good idea to know all the dressing materials that you're using. Adaptic is a wound contact layer that is made of nylon. There is even Adaptic Digit, which can be used for finger dressings. Both of them are made of nylon. Silicone wound contact layers such as Askina Silnet, Duratouch, Silflex, Mabitel have the advantage that they can be left in the wound for up to 2 weeks. Remember that these are inert, so they don't get infected, they don't react with the body tissues, and they permit a free exchange of exudate um, through the silicone, because the silicone has multiple pores. So go ahead and use these even for uneven wound surfaces, because they will start adapting to the wound. These are excellent, especially when there are chronic wounds and when the tissues exposed below them are very delicate. So the granulation tissue will nicely grow over those tissues, but they will not penetrate the silicone. So silicone will help prevent any damage to these delicate tissues. SpongeBob SquarePants. This is exactly what a sponge looks like in the deep blue sea. Not SpongeBob SquarePants, but the photo on the left. Now these are called true foams, because if you look at the structure, it is nothing but a foam which is very stiff, and it has multiple pores which are interconnected. If you take the same foam and you fill the spaces with hydrogel, this becomes a pseudo foam, because the spaces are interconnected but each space is now filled with hydrogel. So the advantage of a foam is that it can absorb fluid by capillary action. But you squeeze the foam or you squeeze the sponge and the fluid comes out. So in case you want to lock the liquid inside the foam, you create a pseudo foam. The hydrogel now will suck in the fluid, lock it there, and on squeezing the foam, the liquid doesn't come out. So the foam, when it is stiff and when it's full of fluid, can even comfort the wound by some kind of a spongy layer there. So pseudo foams have the advantage over foams that it doesn't leak out the fluid, it adds to the comfort. It can even prevent infection, because once you lock in the exudates are not there to act on the wound, and the bacteria doesn't have enough of material or enough of raw material to cause further infection. Now this is what commercially available PUF or polyurethane foam looks like, but we are not using this for wound dressing material, are we? What you're seeing on the right is a scanning electron micrograph of the open cell structure of the PUF. You can see that it looks just like a sponge. It's having multiple spaces which are interconnected, and this helps in the capillary action of the foam. As you have seen, the advantage of using foams, and the different foams that I have shown here are Askina foam, Optiform, and Mepilex. As per the company, Optiform can be kept on the wound for a period of 7 days, that's 1 week. Again, it's because of the technology of completely absorbing all the exudates inside the foam, and it doesn't permit any exudate to act as a substrate of the bacteria. In addition to which, there is also some degree of PHMB and silver which is there inside the dressing, which helps to retain the dressing there for 7 days. So go ahead and use these foams for wounds which are exudating, wounds which are in the sacrum, wounds which are in the foot. At the same time, they even give some comfort value to the patient when they use some pressure over the wound, because there is a shock absorbing layer which is a physical property of the foam. I previously explained the difference between the true foam and the pseudo foam. Pseudo foams, as you know, they have a very high absorptive capacity. Therefore, you put a layer on top of the pseudo foam which is called the polyurethane film. You have a polyurethane foam and a film. Examples of polyurethane film: Tegaderm film, Opside film, all these are made of polyurethane. Now in the next few slides you're going to see different kinds of pseudofoams which have been used. There is a top layer of polyurethane film. Yes, it's of different varieties of colors, and you may even have silicone or nylon on the wound contact layer so that it prevents adherence to the wound. Alvin plus adhesive, TL, TL plus, and also I have shown that you are having other dressing materials. Remember that most of them are interchangeable, so if you don't have one, you can use the other. This is a different company and this is a different name. Well, it takes a lot of ingredients to make a nice biryani. When everything comes together, it's very tasty, isn't it? Likewise, there is a material called Enlakstra, which has taken so many different dressing materials and made a single material from the company called anywound.com. It can be used on any wound in different stages, different exudate levels, different infection levels. So I'll show you these things in the next slide. Well, Enlakstra is made of super absorbent synthetic polymers. It also has inactive bioinert components. Well, to say it in English, they've taken alginates, hydrogel, certain other polymers, combined everything so that it looks physically like a foam, but actually it behaves like a pseudo foam, because inside the areas which are open, which can have capillary spaces filling up air, it is coated with certain materials which form a hydrophilic gel. So it has the advantage of a foam, a pseudo foam, hydrogel, alginate. On top of it there is a wound, in a sense, barrier layer, and below there is a wound contact layer. Rather, the whole thing acts as a wound contact layer. The foam creates different variable pressures, which I shall show you in a special presentation on negative pressure wound therapy. So there is a microstrut effect on the granulation tissue, thereby it even promotes granulation tissue. Here there is a complete absorption of exudates. There is no substrate for the bacteria to act, and this prevents wound infection, or rather, even if there is infection, it reduces the bioburden. I have taken some screenshots from the company website and put it on the presentation because the company claims that you can use Enlakstra on the wound for 7 days. I repeat, 7 days. Okay, so remember, this is a special patented technology, and it has no latex, and it has no active medications. So there is no silver, there is no antiseptic agent. It is only the principle of complete absorption of exudates which makes Enlakstra so effective. As mentioned, Enlakstra is painless on removal. It protects the healthy granulation tissue. It ensures moist wound healing because there is a moisture balance between the dry and the wet. There is no skin maceration. There is no desiccation of the wound bed. It also supports autolytic debridement because there is a layer of fluid which is kept in between the wound and the Enlakstra, because there is a hydroactive layer there. Now the Enlakstra, if the right size, can be kept in the wound for a week, and it can be used for wounds of different kinds of drainage, low exudate to high exudate. If it's a low exudate wound and you want to keep Enlakstra for a long time, you can even charge the Enlakstra a little bit with saline. You can use Enlakstra in case you don't want to use negative pressure wound therapy, and if you have a very heavy exudate in the wound. So how exactly does one go around using Enlakstra? Clean the wound and the peri-wound with sterile saline. You can even use the other cleansers that we mentioned before, like UCS or SAF cleanse. Once the wound has been cleaned, you can change Enlakstra once every 2 to 3 days for the first 2 weeks, once you have the slough and the odor that have come off. But on the first, when you start, if you don't have too much of slough or odor, go ahead and use Enlakstra and change it once every week. In the likely event that you had too much of slough and odor and you used it once every 3 days, after about 10 days to 1 week, 10 days to 2 weeks, you can change the dressing once every week, and you can do this until the wound is healed. Remember, you can use the same dressing material from the start till the end, because Enlakstra can be used for any stage, any type of exudate, any type of wound. Thank you so much for watching the video. If you'd like to contribute any points, or you like to edit them, or you feel that something is amiss or should be updated, either leave your comments below or send me an email. Thanks again.